Welcome, everyone. This is IC 27, Considerations for Dependent Mobility for the Pediatric Client. My name is Madeline, and I will be moderating today's session. We will provide the CEU code at the end. Just before we get started, please remember to mute yourself, and questions can be asked using the chat feature. I will go ahead and turn it over to Linda Bollinger, your presenter for this session.
Well, good afternoon, everybody, and welcome to my session on considerations for dependent mobility for the pediatric client. My name is Linda Bollinger. I am a physical therapist and ATP. Just a little background about myself before we get started. I ran a seating and mobility clinic on Long Island for 20 some odd years, mostly with individuals with developmental disabilities. And then 3 years ago, I moved to the West Coast, where I currently live. I moved to California and I began working for Sunrise Medical. And this class, Dependent Mobility, I actually wrote when I had my position with Sunrise as their clinical educator. I will share with you that since then, I moved over to the Lecky Pediatric Specialist, and I was fortunate enough to be able to continue to present this with this new role that I have. And I hope you, if you have any questions, if it's a burning question, you can certainly unmute yourself and ask it. But if not, we'll put it in the chat and we'll try to take those questions at the end of the session. I do have the ladies, Laura and Madeline, moderating that because I'm not real great with my presentation and chat, but we'll go ahead and get started. So just as I said, I am the pediatric sales specialist for Lecky Products and a full-time employee of Sunrise Medical. And you will see some pictures of some of our Sunrise Medical products, but it doesn't mean that I'm endorsing any of those products. In fact, I'm a big believer in trying multiple manufacturers when we're doing our eval, and we'll even talk about that a little bit. So our objectives for today, upon completing this course, I hope that you'll be able to identify 3 ways in which delays in development in the pediatric client may impact wheeled mobility system recommendations. You'll be able to list 3 emotional considerations when recommending dependent mobility bases for the pediatric client, and identify 3 components of dependent mobility base that can address the potential needs of the pediatric client. And my plan for today is to go through the growth and development of the evaluation process and some dependent mobility options. And what I'm hoping that you'll do is just kind of think a little bit differently than maybe you've been prescribing currently mobility bases, and just have different considerations. And so really what I'm just trying to do is to create some thought-provoking ideas. And so with that said, this slide is just a really rudimentary look at growth and development. During the first year of life, a baby grows an average of 10 inches and triples his or her body weight. That rate continues to grow. The growth rate continues from 2 years to adolescence at about 2.5 inches per year. And so the femur length is about a quarter of the overall height. And so think about how tall the child is and what their seat depth might likely be. And the sitting height is about half. Again, very rudimentary. These numbers are just a little bit of a chart that I found. And why I thought it would be good to include this is when we start thinking about growth, how much growth are we actually looking for? And so this chart is kind of like a little synopsis of that, and not in any way meant to be, the end all. It's just really to get you thinking, like, how much do I need to build into when I'm thinking about, this pediatric client? With growth and development, there are a few areas of development that you want to be thinking about, and that's the physical, the motor, the cognitive, the socio-emotional, the sensory, and language. And these domains each develop simultaneously. And what we find is that if one area is unable to develop, it can negatively impact the development of other areas. And so what I have also found in my own practice is that when one area meets a milestone, then sometimes the others start to follow. And we see that sometimes when we give mobility, all of a sudden the classroom teacher comes back and says, they're starting to talk a little bit more. And that makes sense because now they're able to integrate with their interact with their peers. So their socio-emotional development starts to increase, which also leads to cognitive improvement. So by looking at trying to develop milestones, especially in the physical motor area, we will see some carryover into those other domains. So taking a look at this chart, just briefly, we look at birth to 3 months old, the child is lifting their head and prone. By 6 months, maybe they're moving their toy from one hand to another. And 7 to 9 months, think about sitting without support. By 12 months, we're seeing standing, creeping, and that's standing and creeping, maybe not active walking, but they're kind of moving along the furniture, exploring their environment, a very important milestone there. By 13 to 18 months, they're walking, and then kicking a ball at 24 months, and then maybe jumping at 2 to 3 years old. And what I want you to think about is, when do you start to introduce adaptive equipment with these milestones? Does it make sense to introduce them when their milestones aren't being met? Another way to look at development is with the World Health Organization's ICF. They developed a series of F words for the child neurodisability. And this is like a new way of looking at things. It's not necessarily the sequential, but it's the overall look at the child. And so these F words include the function, and that's what people do. And what does a child do? A child plays. This also includes their body functions, such as respiration, digestion, and elimination, right? Those physical. It's looking at what most people do and how we can create this, right? And think about also function is not how it looks when they achieve it, but the fact of achieving an activity. So sometimes, the gait isn't perfect, but they're able to get from one place to another, or it takes a lot of effort, and it's not necessarily how it looks. Another F word is the family, and this is essentially the environment of the children. The family is part of the child, and the child is part of the family, right? And so this is really important, because when you're making your recommendations for seating and mobility, the family dynamic really does play a lot into it. Is this a family that goes hiking? Is this a family that goes to the beach? What is it that they do as part of their natural activity that you might need to consider when it comes to making these equipment decisions? By supporting the family, you're supporting the child. Fitness or physical activity. This is how the child stays active. This is not physical therapy or occupational therapy. It's really activity outside of that. Think of exercise, adaptive sports. Do they participate in yoga or dance class? Including those activities in your wheelchair recommendation, or being cognizant of that. That's the things that they're going to do to be whole. Sometimes friends are more important than the family to some kids, right? And so friends is their social circle, and social development is essential. We talked about those domains before, and how when we develop mobility, perhaps that the social development also, and vice versa. So by developing social, you also create a desire for movement, right? Encouraging friendships and giving the child opportunity to meet other children. How does that work with maybe the seat height of a wheelchair, right? Or what other assistive technology can you get to have them integrate with their friends? Fun, enjoying the activity. Besides the activities that they do for fun with their families and friends, really, what does the child enjoy doing? What's their favorite color? Do they have a sports team? How can I make this process of ordering a wheelchair and being in a wheelchair or dependent mobility fun? Do they go on outings? What outings do they go on? So where will they need this mobility device, right? So those are the things that you want to think about when you're making your mobility recommendations. And lastly, what's the future? What's the plan for the future? This is what we're talking about. We're talking about developing this child, right? And so you want to think about the strengths that they have now, right, and support them today. But you also want to think about what you're hoping or what the plan is for moving on. Is it going to be that they're not going to be in a mobility device and maybe they're going to be in a gait trainer or something like that? Or maybe now they're not self-propelling, but potentially they will be self-propelling. And how and when are you going to implement that? Just considering the future with your wheelchair recommendations. So when we're talking about development, we do have these developmental milestones that we're hoping to meet, but we also have this big picture of childhood development that we want you to think about. So I want you to consider, how and when should mobility equipment be provided? So we talked about those milestones before. Are you making recommendations for a mobility device when you've tried therapy and ambulation and you've decided it hasn't been achieved, it's not going to be achieved, and you've waited till potentially 2 years, when we know that that milestone is more like 13 months? Or when the milestones aren't met, do you start to say, what assistive technology can I use to assist this child in meeting these milestones? So even though it's adapted, right, how can they meet those milestones? And why do we like that? Is because if we start to encourage those milestones to be met, those other domains of development start to kick in, right? And so think about it. Could the milestones be met even with adaptive equipment? So like sitting with seating systems, or standing with standers, and ambulation with the gait trainers, mobility with those mobility devices. And so this is pretty self-explanatory, but what I'm suggesting is that we can introduce them potentially sooner than maybe some of you are. I know ambulation always seems like the end goal, but really, is it ambulation or is it mobility and exploring and having experiences? And the other thing is that recommending one type of assistive technology does not mean that you don't need the others. So just because you have a standard doesn't mean you might not be working on ambulation, or just because you're working on ambulation doesn't mean you don't need a mobility device. So you want to be thinking about what adaptive equipment you can use. And then lastly, how can you use these F words to impact your recommendations? So for example, function. We know that if we have good positioning, we're going to improve those bodily functions. As I said before, does the family dynamic impact those recommendations? Sometimes the family just can't maybe handle a wheelchair at the time, and maybe a stroller is more indicated for them, and you might have to consider that. Or do they go to the beach or go hiking and you want knobby wheels, even though maybe that's going to add a little weight to the situation. Certainly friends being able to looking at the height of the seating systems, and what's the future on that. So just think about these words when you're making those recommendations. So using adaptive equipment to meet developmental milestones. So what we have is immobility versus adaptive mobility. And when the child is immobile, they have minimal experience with gravity. It makes it difficult for them to integrate the sensory motor skills. But when we start to add this adaptive mobility, we can develop that response to gravity. We can activate the vestibular system. We can improve their spatial awareness, their depth perception, and their weight bearing, right? And so by providing this adaptive mobility, we do see some really great benefits. In addition to that, we have the benefits of positioning. And all of those benefits include vision, communication, social interaction, cognition, being able to be upright and access their toys or being brought to their toys, body control, Fine motor development. If we're slouched with poor position, it makes that passing the toy from one hand to another more difficult, or fine motor more difficult. Core strength development. Again, that bone and joint health, respiratory health, gastrointestinal health, skin health, and somatosensory development. So what I'm suggesting is that although we know that traditional therapy has its place, we may want to consider these adaptive assistive technology, or the adapted equipment during that process to assist in that development. So I like to include the CRT, roadmap, just because I think that it's important to have a plan in place for our evaluation. Although you may not do all of these as separate appointments, it's great to have the components together. And so I think my timing's on, and so some of my slides are getting moved. But anyway, so we have our referral. Then we have our needs assessment, and then we have our hands-on evaluation and feature match, our equipment recommendations, our documentation and a submission for funding, our approval, and hopefully not an appeal, but an appeal if you need it, ordering the equipment, our fittings and delivery, and then our follow-up plan. And so, like I said, I feel like this is something that you want to have in place, what your plan of attack is going to be. And maybe some of them are going to be separate appointments, maybe some of them will combine, but you really want to have that general plan. And so we're going to go into this a little bit deeper. And we want to evaluate, when we get that needs assessment or the referral, we want to evaluate for the need, not for the specific device. And what do we mean by that? Let's say you get a referral for evaluate for a stroller. What happens when you start to do this needs assessment and you say, if you just were going to go straight to ordering the stroller and you didn't do your needs assessment, you may say, oh, get the stroller. But then when you meet this child, maybe you say, you know what, stroller is not indicated. This child really is going to be an independent propeller. I'm going to go for a manual wheelchair. So you really want to have your needs assessment done. You want to think about what the parents need for their home and community use. That's going to have a big play into what your recommendations are. What are their transport needs? Do they need to fold it? Does it need to stay intact and they're going to put it into the back of the van? What are the funding requirements based on their insurance? Is there any other funding available? And what are the goals? And then you want to think about what's the client's medical history, and I like to call it the medical future. What is their diagnosis? What are surgeries, either previously or upcoming, and what are their medications? With surgeries, it only has to happen a couple of times where you don't ask about what's upcoming and you do a custom mold and they get a G-tube a month later, or they get a spinal Harrington rods and your custom mold does no longer fits, So when you know about that, you can plan for the future. You want to ask about what equipment the child has, not just their wheelchairs, but what about orthotics? What about standers? What about gait trainers? When did they receive it? Does it work still? Is it meeting their needs? Who funded it? How long ago? So you want to do this needs assessment to really get a good idea of what's going on and why they're there for the referral, for the equipment. And then when you think about goals, everybody comes to the table with some different goals, right? And so what we want to try to do is make a plan with the goals. That child peer interaction is one of their major goals, right? Independence, fun, exploration, learning, and aesthetically how it looks. The family a lot of times has important goals as well, but often sometimes different. They want that low profile, aesthetically pleasing mobility device. They want it to be acceptable. They want their family to like it. They want it to be accessible and easy to use and comfort, right? And then the therapist like myself, we're really into that good positioning and we want to complement our therapy goals. We want independence and safety. And sometimes we get really hung up on what we want and we don't listen to the others. And so we really want to be considerate of the other goals. And then unfortunately or fortunately, we have the last F word, and that's the funding source. And so the funding source is really what sort of is overseeing our recommendations. And I want just to be clear that our clinical recommendations and meeting funding criteria are two separate things. We know that some things are clinically needed. We have good justification for them from a clinical point of view, but sometimes they don't meet the criteria that the funding source says, whether it be time, frequency criteria, or whether it be diagnosis driven. We want to be clear that they're two separate things. And based on that, we just know that the funding source does have a big impact in our goals. Moving along, we have our assessment. So what I'd like to say to you is some of you may be out there as treating therapists. Some of you may be out there as the suppliers providing this, but really and truly, you want to take a step back. If you're that treating therapist, take off that treating therapist hat, put on your seating and mobility hat. Sometimes you don't see the trees from the forest. I think that's how it goes. It doesn't go the reverse, right? But sometimes you're so into seeing the child week after week that you don't see the changes that they're making or the need. So you really want to kind of take a step back, observe that child in their current equipment, do a good mat assessment on a firm surface on the mat. Look at what the response to gravity is. Is it a fixed asymmetry, or is it reducible? What's going on with that, with gravity in both. So you're looking at them in both supine and in sitting. Take your subjective and your objective measures. Subjective measures is your descriptive terms. Patient has an obliquity. Objective measures, you're going to discuss the angles of that obliquity. You're going to look at that pelvic angle. If you're not familiar with the standardized language, I have a resource at the end to direct you. But you really want those objective measures. It helps you for currently making recommendations, and then also if you need to make changes in the future. If you say the child has a pelvic obliquity with no objective measures, and then next year you see that it's worse, but you have no proof because you didn't take those measures, what's to say that the funding source will approve it? They'll say they had a pelvic obliquity last year. What do they need another a change in their seating system this year? And you want to document everything. You want to document your appointments. You want to document what you've chosen, all of your assessments, what you've ruled out. All of that is great support for your justification. And then when you go ahead and do your feature match, I like to narrow down to the category of equipment. So we got that referral that said, evaluate for a stroller. Am I staying with that category, or am I going to move to my manual wheelchair, for example? I try to have more than one product available for my feature match. Even if I have what I'm leaning towards or what my favorite is, I want to be able to say that I ruled it out. And I think it helps with my justification process. Let your families try folding the equipment, lifting it, pushing it, getting in and out of the car. You may think that this is the best choice, but if the family isn't going to be successful with it, it's not the best choice. Lead with your clinical recommendations. I know that this is sometimes really hard to do. The funding is so overpowering with what we're doing right now. So I say, I think of it as, this is what I want to achieve clinically. This is what I think will achieve that clinically. However, based on my funding restraints, this is what we can do. What are we going to do if we don't think something's going to be covered by funding? Do we want to go to an alternative source? What do we want to do? So lead with that clinical and then try to create a team consensus for your final recommendations of equipment. As I've said repeatedly, the challenge is funding. Funding is really, we're hearing this in multiple sessions, that the funding source, limits what we can get, be it diagnosis, be it, changing condition, be it frequency limitations. However, we want to realize that when we have our good clinical justification, we can go to bat on that for sure, and we can go to the funding source with some really good positions. I would not say to necessarily not recommend something because of funding. You really want to stay, like I said, with that clinical lead. Having good notes really does help in this process. So we talked about leading with the clinical, not what is covered, including your clinical notes and your timeline. When we talk about least costly alternative, that doesn't mean the cheapest. Um, if something is less expensive but will not meet their needs, it is not the least costly alternative. So you need to be able to justify or discuss why a lesser expensive product will not work, right? Cheap is not the same as least costly alternative. I think you need to be prepared to resubmit with additional information and attend an appeal if you have that opportunity. I have found that if you go to an appeal and you're prepared with your notes and why you made those decisions, rational decisions, and you bring your family and the end user with you, that you can have some success. Sometimes it's submit again, but a lot of times I've had an appeal, a denial overturned. I do think it's a game of endurance, who could stay with it the longest and be timely. You cannot let these things go on. So if you get a request from funding for additional information, you need to get back to them. And you should have the information there because you're doing these great assessments. And then really with funding, there is that potential for denial. And so what is the plan? Is the plan that we're going to ask my rich great aunt for the money? Is the plan that we're going to get a certain item for Christmas? Is the item, we're not going to take the item, we're going to resubmit? I think you need to all be on the same page when it comes to the denial. Everyone has a different request when it comes to that. So fittings and final delivery. I think you should have an interim fit if necessary. Pretty much always consider that delivery an interim fit, so you're not disappointed when it doesn't go as planned. I'd like to have the clinician and the RTS, the LCM, the licensed clinical medical professional, and the RTS at the fitting. I like the family to practice. I take pictures of the positioning, prepare notes if you need it, or directions, and deliver if it's correct. If it's not correct, sometimes it's not worth putting. I know that people get disappointed, but sometimes it's a lot harder to go back in when after you've delivered an item and to correct it. If things look good at that appointment, it's not. I think it's great. It's an opportunity for the technician to go ahead and bring it to the home and do the fitting at home if that makes life easier. Follow up. I think you need to consider a 4 to 6 week follow-up right after delivery. With children, especially who are dependent in mobility, you start to see you might see some changes really early on with their response to the equipment. If they haven't been in it, if they're in something new, just being jiggled around, or their family life activities, you'll start to see some changes that maybe you didn't see at the delivery. Whether it be, they were nervous and their tone was high, or they really were uncomfortable, or not used to the equipment. So then after that, schedule those routine follow-ups, 6 months to a year. We did 6 months the first time, and then yearly after that. And this is often the only time that you get to see changes in positioning and needs and growth. And even if you're that treating therapist, a lot of times you don't see it until you actually take a step back and have an appointment and then really dissect and look at the pieces. This is, so it really is often the one way you can check to see that what you've recommended is still appropriate. So let's consider, sometimes the assessment leads to the equipment that wasn't originally considered. The assessment is critical, even if you are just recommending a stroller. Families often have priorities that are different than the therapist, right? Funding will impact the recommendations and require compromise. Consider these alternate fundings. Oh God, today we've heard a bunch of GoFundMes, but I think that's an opportunity. But certainly you have to still have a plan about how you want to consider that alternate funding. Trialing the equipment is a great way to make sure you remain non-biased. And truly, you might have your favorite. Could a lesser product work? And so you consider that, right, by trialing the equipment. And your documentation is your best defense against these funding challenges. When you're really, when you have really objective measures and decisions and reasons for why you chose something, it's a hard thing for someone to deny. So getting into dependent mobility options. And so what we're going to talk about today briefly is our high-low bases, our adaptive strollers, and our tilt and space wheelchairs. And so I have some pictures here, and we're just going to get into them a little bit deeper dive into each of them. So high-low bases. You know, I include this even though it's not what we consider our traditional mobility base, but high-low bases do assist with mobility within the home and potentially the school, right? Mostly on these small caster wheels, but like the name says, these chairs can go low to the ground, they can go up at the table height or even higher. And so what this allows is this mobility within the home with good positioning, thinking about that seating, right? It can offer alternative positioning to what to maybe the stroller and or wheelchair that the child is sitting in. And it allows for peer and family interaction when we're thinking about those F words. How can I engage this child with their peers? How about by bringing them lower to the ground, right? Family interaction. How do they participate at the dinner table? By bringing them up to table height, right? So they're not sitting alone in their wheelchair. Right. So this is a good alternative or a good option for within the home. And so why a high-low base versus an adaptive, or not why, but some differences between what you would get with a high-low base versus an adaptive stroller. First off, high-low bases, although we discussed the benefits of being able to go to different heights, funding is often a challenge for the base of a high-low, not necessarily for the seating system, but for the base. Many funding sources do not consider that to be medically necessary, and will likely try to gear you towards a more traditional mobility base. But they do have pretty good style, weight. And so aesthetically, a lot of families like it, but also it gives this really good support. In terms of but as we know, it is not foldable. It cannot go on the bus. It's not going to be able to be brought into the trunk of a car. So for that reason, when you need to go into the community, this is when you start to look at your other two devices, and that would be your adaptive stroller, which is going to have ease of transport, right? Most of them are easily folded, right? Most are lightweight. And then the weight of them, in terms of what they can handle, you have to be cognizant of, and you really want to make sure that what you're recommending will be good for the child that you're recommending it for. And many of them will be crash tested, and so their transit options are available so that you can actually tie them down on your van or your school bus. So there is a need for both of them, and some of these high-low bases can go on mobility devices. Some of the seating systems can go from a high-low base to a mobility device. So we'll talk about that in a little bit. But then we get into that adaptive stroller. And who can benefit from those adaptive strollers? We don't want to just think babies, okay? Any young child who's non-ambulatory but not ready for a wheelchair. And when I say that, I mean maybe the family's not ready for the wheelchair, or you just think that or they're just really too small for a wheelchair. Older children with behavioral issues or elopement issues who are non-self-propellers. So when you put them into the seating system, into the adaptive stroller, they're safe. Children who fatigue, maybe children who ambulate during the day and have either seizures or get tired, maybe need a mobility device for the end of the day. And some children need a transport device. They're not safe on the school bus, but with a transport device, they can be transported safely. Note that families often choose strollers instead of wheelchairs. And so this is where we start to think about those F words in terms of the family needs. Why is that? Maybe you do a deeper dive into why they're choosing a stroller versus another mobility device. So let's consider when you're having this stroller talk. When is it appropriate to recommend an adaptive stroller for a child? Is it once the diagnosis of a developmental delay is made? Is it when they've outgrown the current stroller? Is it when they don't meet the milestones of sitting? So you want to be thinking about when is it that you're going to be recommending an adaptive stroller for a child. And to do this, what's the best way? And for me, I think it's really being prepared. I I have experienced not being prepared and bringing up the topic of a stroller, adaptive stroller, and it was as if I was the person who brought the negative energy to the family, or they weren't prepared for the fact that I believed that their child was going to need a mobility device. And so sometimes we are the bearer of bad news, but being prepared really helps that. Number one, discussing some of the diagnosis and what you see in terms of the child's potential, discussing that, discussing the benefits of a adaptive stroller versus a traditional stroller. And then understand that a family may still tell you no. And why is that? Like I said, sometimes they haven't really understood that there was going to be a long-term disability diagnosis, or maybe they're just think that it's going to cost them too much, or maybe that is a kind of they're in denial, and this is kind of like the first time they're really hearing about this. So you really want to be prepared that they might tell you no, and understand that there's a lot of emotions that go along with recommending an adaptive stroller. It's seemingly to us who are recommending this that it's no different than that traditional stroller, but that in fact is not true. It is really it is an emotional time for families when you start to discuss adaptive equipment. So adaptive equipment and a standard stroller versus an adaptive stroller. I think it's important to realize that families still often want it. And why is that? It's still mainstream. It tends to be a lower profile, but it only has a standard seating option. You're not going to get that tilt and recline that you'll get with other adaptive strollers, and it's easily transportable, and it's what they have and know, and they're used to it. Whereas that adaptive stroller can offer seating and positioning. It's usually more durable because it's a durable medical equipment. You have that storage and accessory ability to put like O2 or vent trays on them. You have a change in the seating system. You can offer tilt and recline. You can, many of these will be transit options. We'll be able to actually tie it down in the van, and you have that foldable base, and it's covered by funding. And that is often the precipitous for families to accept it. The child may be outgrowing that standard stroller, and you say, but you can get this one, and it's covered by funding. And so sometimes that's actually a gateway into it. So just let's think about the bases of the adaptive stroller, right? You want to think about the configuration. Do you want the child to face the caregiver or away? And if that's what you need, what does it take to change the configuration? If it's too complicated, families are not going to do it. So you want to have them try that to help you select the configuration. What is the weight limit of the stroller? Is the age of your child, number one, are they too large and over the weight capacity? And is the type of stroller that you're selecting age appropriate? Because although the child may have a disability, we do still want them to appear appropriate in the durable medical equipment that we're choosing. What is the growth capacity? Is it easy? How much has been built in? When we looked at those growth numbers, do we have the ability to get a couple of years out of the stroller? So a lot of funding sources are still looking at a couple of 5 years. I don't know about on strollers in every state, but it is something to consider. And then the tilt. Can you go into posterior tilt, anterior tilt, and how much? How much do you need? Will this stroller base meet that need? And then recline, some have just a limited, but can you have a full range? And then can you get tilt and recline and elevating leg rest with the stroller base that you choose? The adaptive strollers, many of them will have the ability to add supportive seating. And so some will be a little bit more, just a little bit like a umbrella style, right? But once we get into the seating considerations, you want to think about what surface you need. Do you have a firm surface? Do you have positioning components like hip guides, knee supports, medial knee supports, head supports? You want to have the ability for these to be added. and support as much as you can, while still allowing the child to grow. So let's consider why it is important to move a child from a stroller to a wheelchair. One is for positioning, right? Although those strollers had some positioning, it's really not that dialed in, right? We want the child to be in something that's age appropriate. We want the seating to be able to give them access to their environments and all of the benefits of seating, right? And so because of this, many times we are, again, the individuals bringing this to the family's attention that it's time to move from an adaptive stroller to a wheelchair. And again, we sometimes get this hesitation from our families, right? Why is it that they hesitate? Strollers, even adaptive strollers, still look more mainstream, right? It also gives the sense of that less disabled, and I put that in quotes, right? They often are more accessible, even just because of the ease and the weight of them, getting them from the home and getting them transported, right? They tend to be more accepted. Families are used to seeing kids in strollers, right? And then sometimes they hesitate because they don't understand that there's funding available, and they think it's going to be a big expense. So again, when it comes to discussing this with the parent, the same thing holds true as it does with moving to a stroller, and that is that you want to be prepared, you want to be clear with your message. You don't want to do this, haphazardly at the end of a session. Oh, by the way, I think they need a wheelchair. You want to be cognizant of the family's emotions that will go along with this, and have a plan if they say no, right? And then think about it. Can you bring in other family can you bring other families or children that are in wheelchairs to help along with the process, and other peers and other professionals to help with that process? I sometimes think that the person that has the best relationship with the families is the person to give this, to make this recommendation. So thinking about tilt and space wheelchairs. Things to consider are the seating compatibility. When you get into a tilt wheelchair, you want to be able to, you got to decide whether you're going to include standard seating, a seating system, or custom. What do they need? Do they need just tilt, or will they need recline as well? And what components do you need? I wouldn't call them accessories. These are important components for the seating system. Head supports, upper extremity supports, lower extremity supports, what positioning belts, and what wheel options. And then as a side, and in terms of what selection you're making for your frame, what is the weight and the weight capacity? How does it fold? How do you configure it? And what growth can you build into your tilt and space wheelchair? So looking at the tilt technology a little bit, just to bring your attention to it, in the first, I just have the two pictures of one with a traditional or tilt with the posterior axis. Note that it's one single pivot point, and what happens is when that tilts back, the footprint of the chair increases. However, some families like that style. You put a canopy on it and you could kind of make it look a little stroller-like with the small wheels. Sometimes that's a good transition. But in terms of the other type of tilt technology, we have a center of gravity where we work along a pivot point, and we pivot around the center of the patient's gravity, and the footprint stays small, so the turning is easier and manipulation of that is easier. As far as folding the chairs, tilt chairs, we can fold it in traditional with a cross frame, and we can get it pretty small. But we can also get with a traditional folding, just bring down the back canes and remove the rear wheels, tip it on the side, and it's not that much larger than what you have. And what I would say about folding is this is really an area where you really want your families to try it out, because it feels like it's you want it to work, and you feel like it's a good option for getting it into the trunk of the car. But in the rain, when you have to take off the seating system and they're folding it, a lot of families wind up opting for keeping it intact and just getting a ramp and a SUV or a van. Unfortunately, sometimes that's the way that it goes. So you really want to make this decision. I find that when we go with a cross frame tilt, sometimes it kind of gets off kilted a little bit. So I tended to recommend a non-folding, or just the folding in with the back canes. But the family still sometimes may want that. And I think that's one of those areas where you're considering the family in this decision. Then again, looking at the tilt mechanisms, can have them on the hand, the back canes, or foot tilt. And again, instinctually, you might have your favorite, but the family really needs to try this. And why I say that is because sometimes, the dad is tall and they like the foot, but then the mom, when it's tilted, she can't reach the foot one, or vice versa. The father can't reach it when it's down. So you need to, play this out a little bit and see what works best. I know sometimes bus drivers are not fans of the foot tilt mechanism, because if they need to tilt it, they can't get behind it, whereas they can kind of grasp the back canes a little bit easier. Again, I don't know that there's any right answer on that. I just think that it's one of those areas where you want to be considering and having other people assist in those decisions. And then I just put in a reverse configuration just for the conversation of, although we're saying this is dependent mobility, if there's that thought that yes, they need to have a tilt in space wheelchair. However, there might be a potential for self-propelling. This is a good option for to be able to do both. You'll get the benefits of tilt, but a child can start to tweak or try to begin self-propelling, excuse me. However, if self-propelling is your main goal, this wouldn't be the direction I would go. Certainly a tilt in space wheelchair is going to be much heavier than any of your ultra lightweight manual wheelchairs. So this is just really for if this is one of those things that you're putting into your future when you're thinking about the F words. So on a wheelchair, tilt in space wheelchair, you need to have your seating system. So on this ladder, you're going to have your basic off-the-shelf seating, which is non-customizable, off-the-shelf that's customizable, seating systems, custom-made, linear and contoured, and then your shape captured or custom molded seating systems. And really, this is one of those areas that you want to rule out lesser, discuss why the lesser item doesn't work, but when you start to do this process, it really makes you really give a good feature match. So let's just talk a little bit about what we're talking about in terms of seating. So some examples of out-of-the-box seating is, just a basic cushion. Sometimes we have these layered cushions where you're choosing between air and fluid. Do you have out-of-the-box seating where you're just moving the hip guides out, or you're adding an obliquity pad or a medial knee support? Or can you modify that seating by doing a cutout? With backs, can you add padding or a lumbar support to customize it, but it's still not custom per se? And this would be that the first two levels of your ladder. I bring up seating systems. This is really a good alternative now. If you really want to dial into some custom positioning, but not get into your custom codes, this is often a really good solution. And by what you can do is you can get an interface that allows the seating system to go onto a mobility base. You can dial in for windswept deformity or pelvic support or abduction, using this, and it still allows growth. So maybe someone really needs some really good control of their asymmetries, but they're going to grow and you're not really ready to get into a mold. This could be a good solution. It offers consistency between your activity chair, which we talked about earlier, and the mobility base, so you can just move them from one place. Aesthetically, sometimes families like it. Like I said, you could even add a canopy on the small wheel, with small wheels, and it can give that stroller kind of feel. So again, a good transitional piece of equipment. For those families that really don't like the idea of a dirty wheelchair with the dirt on the wheels coming into the home, you can use the wheelchair outside with the same seating system, and then use the seating system on that high-low base. And so for cleanliness and storage, sometimes this is you don't have to have multiple devices or keep the wheelchair in the house. However, it doesn't offer alternative positioning. And if that was a goal where you wanted different positioning, maybe you wanted a particular relaxed position during mobility, but you want to have a position of readiness during activities such as eating, you want different positions. This is not going to offer that. But it is a really good alternative for dialing in on those asymmetries, but still allowing for growth. And then I put down, the custom fabricated, whether it be linear, where you're taking the measurements and giving some specs to a manufacturer, or you're doing either like a pour mold or a shape capture with a digitized molding system. You can use custom molded. Downside is that you have to think about how growth is going to be built in, and also that you're going to need a beefed up justification for your custom fabricated seating system. So with growth, we talked about this a little bit, but how much growth is too much? I would like to say that you don't want the child to grow into the wheelchair. You want it to fit at the time of delivery and have the ability to grow. Should be able to grow in both width, depth, and seat to floor height. How quick and easy can these be done? Is it just through moving the back canes? Is it through changing the costume? Or do you need a whole new adjustment kit or a new frame? And then again, think about those seating systems that can allow for growth, but still allow for that dialed in customization. So just some ideas, if you take out that cross frame, that pin cross frame, and you get the neck size wider, you can get a couple more inches of width. If you have adjustable back canes or step adjustable, you can move those back canes as the child grows in length. And then I like to use, you can swap out a 90-degree foot hangers for 70s, and you can get a little extra length out of that as well without having to change the whole frame of the chair. And in the seating system, like having a product where the hip guides are Velcroed and can be moved, or growth tail where you start with the seating system up and then you move it back, or growth in a seating system. So just to kind of discuss a little bit about the emotions attached to this, when you're talking about making a recommendation for a child, getting a wheelchair can be exciting and overwhelming, both financially and emotionally. Sometimes it brings up feelings from the family that you might not expect, and you're wondering, why are they, why is this family giving me so much trouble? But maybe they're uncomfortable with it. You might be the first person really discussing diagnoses with these families, and so sometimes that makes the session difficult. Families worry that the child will be seen as different because now they're in an adaptive equipment. And then they start to think, oh my goodness, I have to move the furniture so I can get this wheelchair through, or it's going to take me twice as long to get to the grocery store. And that is emotionally very overwhelming. Knowing that the family has these feelings and working through them is often helpful. So I think that you have to be understanding of them. And sometimes those sessions are really stressful when you're making these wheelchair recommendations. So you want to be cognizant of that, the fact that this is something you do on a routine basis, but they're not doing on a routine basis. And you could be sometimes the first person discussing some of these long-term needs that the child will have. Some emotions is denial, anxiety, fear, depression, guilt. Sometimes the guilt and anger really make it really difficult for the process to go through. Sometimes the denial makes them choose less a product. So you really want to be aware of them. And if you need to take a break and maybe even discuss, hey, I feel like you're not sure about this. What can we do to help explain it? Or what can we help to get you through this process? And because of that, I think that personalization really helps with the emotions. It helps to get children and families excited about the process. Can you use patches? Can you use colors, their favorite color? This is where that fun comes in with the F words, spoke guards, sometimes this is the only time the child has to express themselves or be a part of that process. And lastly, I just want you to consider redefining goals. We talked about those F words. How do those F words impact the decision that you're making with regard to this? Think about the difference between giving independence, which I know for therapists is such an important goal, but what about giving experiences? Getting the child to be able to go to different places, being accessible. So sometimes maybe that positioning in the tilt and space chair is not the ultimate recommendation, right? Because we want them to be able to experience these other things. Think about, is it about the function or is it about social and interacting? And we carry Kevin. I spoke with him, and he gave me the idea of this alternative accessibility, that he can experience things by being dependent on someone like his friends and his family. And so alternative mobility like backpacks or the upseat. And even though the goal of independence isn't there, the accessibility is there. And so I think we're just about done. We have about 5 minutes left. Is that right? It worked, the timing worked. So I just want to show you these, I put up these resources. We have Seat Freaks, we have Seating Mobility, Canada, Access to Independence, and the book that I was referring to, which is slow to go, but I really think that we all should have the standardized wheelchair seating measures and body surface, and that's downloadable for free. What a great resource that is. So I hope that you can meet my objectives. Hope that you'll be able to identify 3 ways of where delays in development impact your mobility system, the emotional considerations that you have when recommending dependent mobility bases, and the different components such as growth and seating and accessibility when you're dealing with that. So, are there any questions in the chat, Madeline?
Yeah, we have one question. Before I ask that one, I'm just going to throw in the CEU code. It is CPDI20.
I'm sorry, can you repeat that, Madeline?
Yeah, CPDI20.
And that's in the chat?
Yep, threw it in the chat. And we have one question. This may be a little off topic. Do you happen to know of any studies for delayed ambulators using a self-propelled wheelchair in improvement with mental development?
I'm sorry, let me read it. Do you happen to know any study? Oh, where? I cannot off the top of my head speak to any studies that I'm aware of. I can speak to my anecdotal experience with that. With treating children and putting them into self-propelled wheelchairs and seeing the improvement soon after that. But I don't have any studies off the top of my head, but I would, if I come up with anything, I wouldn't mind sending it back out to you all. Anyone else on the line have any studies that they're aware of?
And feel free to come off mute if you have any additional questions or throw them in the chat and we can ask them.
Hi, it's Lauren Rosen. With regard to that question, I mean, it depends on what area of mental development you're looking at. There's lots of studies that talk about like development and depth perception, object permanence, learned helplessness, all of that. There's a lot of research out about that. I'm not sure if that's the mental development the person's asking, but
Yeah.
If that's what they're asking, yes, there are lots and lots of those.
Thank you for that. I appreciate it. So if there aren't any other questions, I think we have 2 minutes. Is there anything else that we need to go over?
Don't forget to fill out the survey back on the ISS website. It'll be on the right, and it will give you an option to like a 4 multiple choice to enter in that code, the CPD I20.
And I'm just going to throw up these resources one last time for anyone that's still interested, that wants to pull them up. And like I said, the really great option. I like to travel with my standardized measures book. Well, thank you everybody for attending my session. And I look hope you all have a great rest of your ISS conference. And we'll talk to you all tomorrow on my session tomorrow. We're good?